Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years. Hello, welcome to today's presentation, Diabetes Management, How GLP-1 Medications Work, presented by Dr. Prasad Katta, endocrinologist with Washington Township Medical Foundation. Dr. Katta is the medical director of the diabetes program at Washington Hospital. He graduated in medicine from the University of Gulbarga, India. He completed his residency in medicine in Great Britain and obtained the degree of MRCP, member of Royal College of Physicians. He obtained residency in internal medicine at University of Medicine and Dentistry of New Jersey and fellowship in endocrinology and metabolism from Charles R. Drew University. Dr. Katta is board certified in internal medicine and endocrinology. His interests include diabetes, thyroid, and osteoporosis. Please welcome Dr. Prasad Katta.
Thank you for that introduction. So we'll be talking about today's topic, how do GLP-1 medications work. GLP-1 actually over the last, I would say maybe 4 to 5 years or 5 to 6 years have been really the one medication which a lot of diabetic patients use. As endocrinologists, we have been using it for more than, I would say, 15-16 years, but they have been more popular over the last 5 to 6 years because of social media and other reasons, and also because they do work. So from the point of view of disclosures, I don't have any disclosures. I do get some samples from the makers of the GLP-1, which include Novo Nordisk and Eli Lilly, and usually we use it to give it to the patients when they are starting or when they need medications in between their prescriptions, etc. So what will I be talking about today? I'll be talking about definition of diabetes, the medications, which are, some of them are older medications, some of them are not so old, the GLP-1 analogs, how do they work, and I'll also be talking about ominous octet, what it means, the benefits of GLP-1 analogs, and the side effects of GLP-1 analogs. So we call it analog because it is similar to the GLP-1 molecule, that's the glucagon-like peptide molecule. This is similar to that, but it's not the same molecule, so that's why we call it as an analog. And again, I just want to let you know, this is a small disclaimer, this talk is for education purposes only. Please talk to your doctor to change any current treatment. Don't base it on whatever I give it on the talk. So what's the definition of diabetes? It's a disorder of abnormal blood sugar levels. It's a defect in both insulin production or its use by the body. Though in patients who produce insulin, they may not be using it well enough because of their insulin resistance. So that's why we say either insulin production or it's used by the body. So insulin is a hormone which is made by the pancreas to regulate blood sugars. So where is the pancreas? The pancreas is situated here, just behind the stomach, and this is what it's depicted as here in an enlarged sort of figure. So what are the medications to use? So in type 1 diabetes, it's always insulin because these patients do not produce insulin at all. They lack the capacity to produce insulin. So that's why we always have to use insulin in type 1. And in type 2 patients, you can use different pills or oral medications, insulin, and non-insulin injectables like GLP-1 analogs. So they are injections, but they are not insulin. A lot of my patients think that they are insulin, but actually they are not insulin. They are definitely different from insulin, and they are what we call as GLP-1 analogs. So what medications do we need to select for type 2 patients? It depends upon where they are with their blood sugar control. Means some of them can get away with only oral medications, some of them may need other medications or maybe 2 or 3 oral medications, and some of them may also need the GLP-1 analogs and insulin. So it also depends upon other medical conditions they have. If they have kidney disease, if they have other problems, definitely we'll have to look at those things before we start them on medications. Like if they have heart failure, kidney disease, so we'll have to be definitely aware of those conditions, the comorbidities we call it, and use those medications accordingly. So the good news is, by managing what we call as ABCs of diabetes, majority of the patients with diabetes can reduce complications. So what does A stand for? A stands for A1C, which is the average blood sugar for the last 3 months, and most patients will be getting, or all the patients will be getting, these labs every 3 months to 4 months to 6 months with their physicians. And usually the goal is less than 7 and sometimes less than 6.5. But if you have any complications, we can definitely be more lenient and have a higher A1C like 7.5 to 8. B stands for blood pressure. Again, goals differ from one organization to another. Most of the time you can say 130 by 80. Sometimes we do accept 140 by 90 also. C stands for cholesterol. We usually use the bad cholesterol, or also called as the LDL cholesterol, and that we want it less than 70. Some organizations say less than 55, especially if you have previous heart disease or heart attacks, strokes, etc. D stands for diet. That pretty much goes without saying, because from the point of view of diet, every time a patient comes in, we have to discuss about that, or at least talk about that, saying that if they're following their diet, a lot of times diet plays a very, very important role in control of diabetes. E stands for exercise and eye exam. Again, exercise, both we want aerobic exercise and also strength training, and eye exam at least once a year. Sometimes it may be more than a year if you have any eye problems. F stands for foot exam, and G stands for glucose monitoring. And with respect to this, we have for a long time we have been using blood glucose monitors. Over the last 6 to 8 years, the continuous glucose monitors have become more easily available, and the insurances cover it, at least for patients who are using insulin. So that is one way to go to look at your glucose monitoring for the whole 24 hours every 14 days, or if you're using a different monitor every 10 days, you will have to change it and look at it, and your physician can tell you what you need to do differently. If the numbers are high, or if they're normal, then you can continue what you're doing. And H stands for health maintenance. So with all these, if you follow these things and also be able to talk to your physician and get to where they want you to be, you can definitely prevent the complications. So with respect to the diabetic medications, there are many new medications in the market over the last 10 to 15 years. Even the first GLP-1 came, I think, into market in 2005, a year after I started in Fremont. The three main categories of medications: the oral pills, which many different kinds, old and new, I'll talk in the next couple of slides. Insulin, there are newer insulins which are more longer acting, and some of them which are short acting insulin. There are also ultra short acting insulins, which you can take it even after you eat your meal. And obviously what I was talking about, the non-insulin injectables like GLP-1 analogs. The choice to allow the individualization of treatment plan is very important, because as I said, different medications for different patients, depending upon the situations, and also patient limitations, like a couple of them, as I told you earlier, is the renal issues or the kidney issues or heart failure and other problems. So this is the ominous octet. Basically, this was coined by Dr. Ralph DiFronzo. He gave us an insight with respect to why there are different causes of high blood sugars. If you start from the point of view of the pancreas here, insulin release is decreased, and the medications which work on that is the sulfonylureas. I'll talk a little bit later, the GLP-1 analogs, which we'll be talking about today, and there's another one called DPP-4 inhibitors. and the incretin effect, which is actually, these are the GLP-1 and the GIP, which is produced by the intestines, and the ones which work on that is the GLP-1 analogs, and there are also the alpha glucosidase inhibitors, but we don't use those medications that often. The TZDs is the one medication which patients may use is the pioglitazone, or called the Actos. This works on the fat tissue here and makes you more insulin sensitive, so that your own body can use your insulin which you're producing, or if you're using other medications which help you to produce insulin, they can use that insulin better. And the SGLT2 inhibitors, these are the ones which are known as either Jardiance or Invokana or Farxiga. They work on your kidneys to prevent the reabsorption of glucose in the kidneys. So basically you will be eliminating sugar in the urine, and so you'll have less sugar in the blood. The medications which work on the muscles, the same TZDs which work on the fat work on the muscle also here, and help you to the muscle to take up more glucose. And also the medications which work on the brain, those are the GLP-1, which we'll be talking about later. And with respect to the liver, usually the liver produces glucose when you're not eating. A lot of my patients come and ask me, how come my morning sugars are high even though I've not eaten anything in the night? The reason for this is the liver has a capacity to produce sugar in the night when we are not eating, and that is usually increased in patients with type 2 diabetes. And the medications which work here, the most important one is the metformin, which is the first medication which we usually use in patients, and also the other ones which work are the GLP-1 analogs and the DPP-4 inhibitors, and also TZDs are the ones to some extent. So now with respect to the pancreas, the other important thing is the GLP-1 analogs also they help you to release more insulin, and with help they also decrease the glucagon production, which I'll be talking a little bit later. So coming to the medications which are old, I just want to give you some information. These are the ones which are from 1980s to early 2000s. When I say early 2000s, it may be more like mid 2000s. The biguanides, that's the group of medication, but we know mainly the medication is metformin, and most patients use this unless they have kidney issues. Sulfonylureas, these are medications which are glipizide, the glimepiride and glyburide. These work on the pancreas directly and help you to produce more insulin, and the biguanides, as I talked earlier, works on the liver to produce less glucose. And the TZDs are the pioglitazone or Actos, that works on the fat tissue to make you more insulin sensitive, so that you use your own insulin better. And these are the meglitinide group, which works again on the pancreas, but they are very short acting. They only work for 2 to 3 hours. So the ideal way of taking this is maybe 10 to 15 minutes before meals. You have to take one tablet 3 times a day, or if you eat 2 meals 2 times a day. And the alpha glucosidase inhibitors, these again act on the gut. We don't use this that often. And the long and short acting insulins, we won't be talking much about that today. So the newer medications, which as I said are from mid 2005 or later, these are the DPP-4 inhibitors. The names are Januvia, Onglyza, Tradjenta and Nesina. If you are taking this and you're controlling your sugars, that's great, but if not, one way to do is to go to the next group, which is the GLP-1 analogs, and the names are here: Trulicity, Ozempic, Mounjaro and Rybelsus. The Rybelsus is the oral form of the same medication, Ozempic. So obviously if you go on this, you'll have to stop the DPP-4 inhibitors. You can't take both together. The SGLT2 group is the Invokana, Farxiga, Jardiance and Steglatro. They work on your kidneys. The insulin, long and short acting, the names are there, and there are combination of insulin along with the GLP-1 analog. They used to be used a little bit more about maybe 6 to 8 years ago. Since we have more GLP-1s now, they're not used that often. And the last one is, which works on the brain to some extent, is the bromocriptine, and the name of the medication is called cycloset. So the initial GLP-1 like substance was isolated from the Gila monster saliva. This is a very slow moving venomous lizard. And the name of the medication is called Exendin 4. So this lizard supposed to eat only 5 to 10 times per year. So that was one of the reasons they were so excited about this molecule, because it was actually first synthesized, or they were extracted in maybe mid 80s. It took almost 20 years for us to develop the first medication, from obviously phase 1 trials, phase 2 trials, phase 3 trials, and coming into medication. And the first medication was exenatide, or Byetta, which I'll talk about it a little later. So that was developed in like 2005, and it came to market in 2005/2006. And the Exendin 5 has about 50% similarity to the GLP-1 structure, and it was shown to reduce both fasting and after meal sugars. So that was the reason. This is the history of the GLP-1, how they were developed. So GLP-1 analogs, again I want to say, none of these medications are generic. They are very expensive to fairly expensive depending upon the insurances. So also they are referred as non-insulin injectables, but more commonly called as GLP-1 analogs. They work upon the pancreas indirectly to increase insulin production and also decrease the production of glucagon. Glucagon is actually a hormone which increases your blood sugars. So that's why when patients have low blood sugars, especially in type 1 patients, we give them glucagon pens as a safety mechanism, because if they are not able to eat or drink anything which is like drink orange juice or an apple juice, or eat something which is sweet, if the blood sugars are low, we tell the patients or educate the patients that they can take glucagon injection and their blood sugars will go up, because the liver, which has stored some blood sugars, releases it. It makes a person feel full by slowing the stomach emptying and also acting on the brain to make the person not feel hungry. It definitely can cause weight loss, and also some of these medications can prevent death due to heart issues, stroke, and other things. So there are different ways they can act, because what I showed you earlier, the ominous octet, very similar to that. The GLP-1s pretty much act on most of these pathways. So if you start again from the point of view of the brain, they decrease your appetite, they increase your satiety, which means you feel full, and they also increase your energy expenditure. And now if you come to the heart, they decrease your blood pressure, they also increase cardioprotection, and your heart rate does go up, but it's not very significant, but it does go up to 5 to 10 beats per minute in some of these medications. And with respect to the kidneys, they increase the sodium sort of loss in the kidneys. Now we call it as natriuresis. And recently one of the medications showed that in the long run they help kidney protection also and prevent death due to kidney issues. So definitely they have a benefit on the kidneys also. With respect to the muscle, they actually help the muscles to take up more glucose and use the glucose oxidation, and so less glucose is in the blood. And with respect to the fat tissue, they sort of decrease the fat mass, which is called lipolysis, and also increase the glucose uptake in the fat. And in liver, they decrease the hepatic glucose production, which is usually one of the reasons the fasting sugars are high in type 2 patients. So they help with that. And with the pancreas, they pretty much do everything whatever right needs to be done in type 2 patients. Increase insulin secretion, decrease glucagon secretion, and they also increase the cells which produce the glucose, which is the beta cells. They increase their survival, and they also increase the number of the cells in the pancreas. And with respect to the intestines and the stomach, they decrease the gastric emptying, and also increase acid secretion. One of the side effects of the medication is reflux, so it is again because of this. and also decrease the intestinal motility. So sometimes you can have constipation, etc., with as a side effect. So if you look at this, a lot of these are positive effects. As long as you can tolerate the medication, it helps you to control your blood sugars and also lose weight and also get the other beneficial effects with respect to the heart and the kidneys, etc. So this I want to show you this. This is the American Association of Clinical Endocrinology algorithm for glucose control. So if you look at this, initially this is the glucose centric algorithm, and basically they say lifestyle intervention, start, continue metformin if appropriate. Obviously if you are not able to use it, then you don't. And in this area here, if you look at it, pretty much GLP-1 is there in every box. Preferred GLP-1 analog, preferred GLP-1 analog. Obviously if you have access or cost issues, then GLP comes down here. But if you're very high blood sugars, again GLP-1 along with the insulin is there. So anywhere you see they are actually using GLP-1 and the other ones, which is the SGLT2s, pretty much second line to first line after metformin. So that's very important from the point of view of using medications. Previously we used to use 2, 3, 4 oral medications and then only start injections, but nowadays if you have to treat diabetes, this is the way to go. So again, this also says if not on goal, continue algorithm for adding and intensifying insulin. That is the other thing. So usually anyone who is not at goal for 3 months or so, you will have to change their medications or add in some more medications so that they are at goal. So this is the American Diabetes Association, ADA, or American Diabetes Association algorithm for glucose control. And this is slightly different. If you use this here, again, use of glucose lowering medications in management of type 2 diabetes, again, diet, exercise, weight loss, all those things. And this is based on what previously the patients have. If you have heart disease previously, then GLP-1 is the first drug, and SGLT2 like Jardiance or Farxiga is this other option. If A1C is not on target, then you can add in other medications here. And if you have high risk for it, like 2 risk factors, again it's the same we need to use the same schematic representation or the formula here. If you have heart failure, then you go with SGLT2, which are the oral medications, because they have been shown to be better with patients with heart failure in the long run. Now if you have kidney disease, again you can use the SGLT2s, and in addition if they are not controlled, you can use the GLP-1s. Now for glucose management itself, if you look at it, GLP-1s, SGLT2s, if they are very high glucose, that's what you want. I'll be going into each individual medication a little bit later. And if you want weight loss, again it's GLP-1 here. So if you look at it in 2 different ways, GLP-1s are very prominent in the treatment of type 2 diabetes in the current picture. So what are the names of the drugs? So the chemical names of the drugs, as patients, most patients may not be aware of it, but I just wanted to give you sort of a background. Semaglutide, that is the name of the medication, and Ozempic is the brand name. And with respect to tirzepatide is Mounjaro, dulaglutide is Trulicity, semaglutide oral, this is the oral medication of semaglutide, that is Rybelsus. These 2 ones were exenatide, LAR, Bydureon, we don't use it that often anymore. And the first medication or the GLP-1 which came is the exenatide, is Byetta, which I think came to market in 2005 or 2006. So again, we can break them down into once a week, which is Trulicity, the Bydureon, which is once a week, which is rarely used. Ozempic is once a week, and Mounjaro is also once a week. And the Mounjaro, one of the positive things it has both the GLP, and there's another gut hormone called GIP, gastric inhibitory peptide. It also helps to control the blood sugars. It has both in it, but all these three only have the GLP effects on it. And once or twice a day is the Victoza, which we used, which was very popular before, but since the once a week came around, it's sort of replaced by the once a week medications, and the Byetta twice a day, very rarely we use it. So what are the benefits with respect to the GLP-1? If you look at it in this table, okay, Victoza, it is approved for control of blood sugars. It's also, there's another form of Victoza called Saxenda that's used for weight management. It has been shown to be beneficial with cardiovascular death, stroke, heart attack. This is what we call as major adverse cardiovascular events. They're positive for this. Trulicity has the control of blood sugars. It's not approved for weight management. It does help you to lose weight, but not approved for it. So they don't have a different drug in with respect to in the same medication. So it is helpful with respect to the cardiovascular death, stroke, and heart attack. Ozempic, again, yes, they have a drug called Wegovy, and it is helpful. And recently, just about a month ago or less than a month ago, it has shown benefit in kidney protection, and this is the only drug right now which has shown benefit with kidney protection and also death due to kidney disease, and they had to stop the study earlier than they had planned. Mounjaro, again, control of blood sugars. Weight management, the name of the medication is called Zepbound. They have ongoing studies as of now, so that's why I've said no. So at this point of time, we don't have any data on Mounjaro. And Rybelsus, again, control of blood sugars, yes. Weight management, no. And with the cardiovascular death, there is, but stroke, heart attack, it's not. So I've said no. But the major cardiovascular events, they were not negative. So I think they didn't have any adverse effects with respect to causing heart attacks or anything like that. So that is great. So these are the medications. Ozempic is here. This is the 0.25 and 0.5. Usually we start with 0.25. We usually continue for 4 weeks. Some patients may be sensitive to these medications, so we may we may just say, okay, you can do it for 6 weeks or 8 weeks and then only increase to 0.5. So usually we do 4 weeks, and then if they tolerate it, we go to 0.5 and keep them on maybe 2 to 3 months, and if they are still need increase, then we go to 1 milligram or 2 milligrams. Trulicity dose, one of the things which I want to tell you in Ozempic is, Ozempic comes in a pen. It's for the whole month, and you can dial up or down on the doses. Some of the endocrinologists sort of go in between and use the pen that way, because if they have nausea, other things, they can sort of titrate up or down and then help the patients to be on the medication. Trulicity, we start with 0.75, 1.5, then 3, 4.5. This is the Trulicity here in the increased dosing. That's what it is. And the Mounjaro, you have 6 doses starting from 2.5 to all the way to 15 milligrams. So it's very important. Why I gave you this dosing structure is, recently there's been a lot of problems with the production of these pens, and the patients sometimes may not get the 10 milligram. They may say they only have the 5 milligram, or they may have the 12.5 milligram. So that's why it's very important, because if you're not using the pen for maybe 3-4 weeks or 5-6 weeks, you may have to dose down to the previous dose, or even the lower dose, even lower than the previous dose, and then go back to the original dose. So that's why I just wanted to give the some idea about these dosing with respect to the different medications. So what are the side effects of the GLP-1? The most common ones are gastrointestinal, which is nausea, vomiting, diarrhea, constipation, and also reflux symptoms. And then in dizziness is one of the things, headaches is one of the things. Very rarely it can cause inflammation of the pancreas, which is bad stomach pain in the center of the abdomen, like someone has punched you in the stomach, and you may not be able to eat or drink anything for 5-6 hours. If anything like that happens, definitely call your physician or go to the ER and make sure that that's not the case. And there's also a boxed warning about thyroid cancer, which is a specific type called medullary type, which is one of the rarer types of thyroid cancer, and it was mainly seen in rats and mice. In human beings, we have not seen that signal, but we still have to let the patients know about it. So that's one of the things. The other thing which I want to sort of just generally mention is when you're taking these GLP-1 medications, if you feel like not eating, you should stop it. You should not try to eat, okay? Even if you feel like not eating, you say, okay, I may want to eat a little bit more, maybe 4 or 5 bites more, because that's when the nausea and vomiting, all those things happen. And try to avoid like oily food, try to avoid very high carb foods. Those are very important also. So that's the end of my talk, and if you have any questions, I'll be more than happy to answer.
Thank you, Dr. Katta. We do have some questions. When taking a GLP-1, are some people still prescribed insulin?
Yes, absolutely, yes. When GLP-1s came on into the market, a lot of the insurance companies would say, oh, okay, if they're on insulin, you can't use it. But that's almost, I would say, maybe 10 years ago or something like that, but it's not an issue. Yes, you can definitely take insulin. You can even take both the long and the short-acting insulin when you're on GLP-1. Definitely the answer is yes. The only thing is, depending upon where your A1C is, your physician has to sort of titrate these doses, either adjust these doses up or down, depending upon where your A1C or your blood sugars are, because it can cause low blood sugars, because if your body is sensitive to the GLP-1s and it is working for you, then you can have low blood sugars.
Okay, thank you. And our next question is, are GLP-1 medications provided to patients for weight loss only that are not diabetic?
Yes, the answer is yes. Again, as I said, the once a day medication is the name of the medication is called Saxenda. If I go back, just want to show you this. Yeah, so this is the one. Victoza is the name of the GLP-1 with respect to the blood sugar control, and Saxenda is for the weight management. And again, Ozempic is for type 2 diabetes, and Wegovy is for the weight management, and Mounjaro is for type 2 diabetes, and Zepbound is for weight management. The Wegovy and Zepbound are once a week, and the Saxenda is for once a day, and all these are for weight management. And there is these are all can be used long term. When I say long term, if patients have to use it for life, they can use it for life. But as long as they tolerate it and with respect to their insurance issues, covers it, everything, then it should be okay. Yes.
Okay, thank you. And our last question is, when would a physician consider a GLP-1 over insulin?
Okay, so both the guidelines which I showed you have specifically recommended that they need to consider GLP-1 as soon as possible before insulin, as long as there is no contraindications from the point of view of the patient. So as an endocrinologist, I would prefer a GLP-1 definitely over insulin, but again, all patients may not be the same. Sometimes we may prefer insulin and patients may prefer insulin too, so we give them the choice and go from there. But the guidelines from both the American Association of Clinical Endocrinology and also American Diabetes Association say that you would want to think about GLP-1s before insulin.
Thank you, Dr. Katta. This does conclude our program, and thank you for this insightful presentation. Thank you, viewers, for tuning in. The entire broadcast of today's presentation will be available on our Facebook page and YouTube.